Welcome to the Golden Hour, the podcast community where moms and moms-to-be hear stories from other mothers and top experts in the pregnancy and postpartum care field. You can visit goldenhour.fm for more information, resources, and all other episodes. You can also find us at goldenhour.fm on Instagram for comments and questions. Welcome to today's episode of The Golden Hour. I'm your host, Dr. O. And today I am joined by a dear friend and colleague, Martina. Hello, Martina.
Hi, Anna.
Martina is a certified nurse midwife based out of Berkeley, California. She completed her nurse midwifery and women's health nurse practitioner training at UCSF in 2016 with a focus on global health and has been working as a full scope nurse midwife in Northern California since then. Prior to becoming a midwife, Martina worked as a rape crisis counselor and a domestic violence counselor, which informs her work as a midwife as well as her dedication to trauma-informed care and reproductive justice. Welcome, Martina. Wow, you are, I've known you are impressive for a while because I've worked with you for several years now, but you're a badass. I'm just going to say it.
Thanks,
and thank you so much for joining us today.
Yay. I'm so excited.
How are you feeling? How are you doing today?
I'm great. I was just thinking about how I remember when you mentioned that you were thinking about doing a podcast like over a year ago, and it's finally here. And I don't know, maybe it lends to, right, it's come to fruition, but it was a really good idea that was, it took a while to conceive, and then you were gestating for quite a period of time.
That's perfect.
But then it's really here and it's really happening. Yeah. And that's really, really exciting.
That's a perfect analogy. I don't think my partner understands like how long it takes to gestate something really great. That's the reason why for humans it's 10 months. Same thing for a good idea of mine. It takes some time. So thank you for appreciating that.
Definitely.
And Martina, I was so excited to bring you on as a guest, not only because I just enjoy you so thoroughly as a person and you're so passionate about your field and your specialty. And I think that there are probably people out there who don't really even know like what a midwife is. I've had patients when I've explained how our practice model works, literally ask me like, what is a midwife? So let's keep it basic. Can you tell us in your own words what a midwife is?
Yes, I think this is a question I get a lot. And it is pretty funny what people's ideas are. I think my favorite story before I explain what it actually is I met someone at a party and I was talking about my work and they're like, wow, I can't believe that you give so much of yourself over. And like, you're so much self-sacrifice and you must really care about what you do. And I'm like, yeah, definitely. And then I realized a few minutes into the conversation that he thought I was a surrogate. Like a gestational carrier, a gestational surrogate. So, which is tremendous work and absolutely involves giving up so much of yourself for the work that you do. But there's definitely a lot of misconceptions about what midwives are. So midwives and nurse midwives in particular are, because there's different ways that midwives can train. And it's really came from the standard when midwifery became a regulated, legalized profession, a few different routes to become a midwife were created. And so I chose to be a nurse midwife, which means I have a nursing degree and then I have a master's of science degree specifically for nurse midwifery or midwifery practice. So as a nurse midwife, my specialty is normal physiological gynecology and obstetric care. So one of the ways that I describe the difference between a midwife and a physician is obviously our training is different, but it's also very much about the approach. So my training really focused on normal and physiological care. And I think a lot of times medical training focuses a lot on pathology, right? Like looking for problems and finding problems and fixing problems, which is really necessary and saves lives and also includes a significant surgical component. And so I, as a midwife, I did not want to go into surgery. And so I wanted to focus really on the normal. And so as a midwife, my training really looked and focused just on the normal parts of OB care and gyn care. And so often I say like, well, in terms of the clinical setting, I'll do a lot of the things that an OB/GYN does, but not surgery or certain procedures that are outside of my scope. But that really lets me focus and preserve and protect the normal physiological parts of pregnancy and labor and birth and gynecology.
Well spoken. And I know you always teach me so much on the job, and I'm so grateful. One of the things I know you taught me was a little bit about the history of midwifery. And even there's someone who I think is known to be like maybe the founding mother, if you will, of midwifery. Can you tell me a little bit more about the history of midwifery?
Sure. And also, I just want to address that I'm very flattered to hear you say that you learn anything from me, because I feel like I just consult with you all day, every day when it comes to the pathological parts of our care, where I'm like, what do I do with this? And so that's why one thing I say to our patients a lot is one thing I really love about our practice is that you don't have to choose between the midwifery model of care and the physician model of care, that you can see midwives for the normal parts of care and then physicians for any complications that rise up. So I think it really lends to, I think like we work very, very well as a team, especially in a hospital setting where people have a medical reason to be there and get care. So midwifery has been around since the Paleolithic era. Like literally there are cave drawings and early sculptures of people who are assisting people through pregnancy and through birth. And midwives really served as the healers in their communities for a really long time. And so sometimes I will jest that physicians have only been taking care of pregnant people for about 200 years. And so I rub it in every chance I can. But again, with a different focus and a different approach. And so midwives have been around for a very, very long time. And in the United States, midwifery has been practiced by indigenous peoples. And then with migration into North America, a lot of European immigrants worked as midwives. A lot of forced migrants from Africa worked as midwives. Those were really who the midwives in the Americas was for the most part, indigenous women, immigrant women, and enslaved women. And it wasn't until physicians really started exploring obstetrics as a field that there was a really intentional campaign by what at the time was essentially the American Medical Association to eradicate midwifery. And it was really a white supremacist smear campaign because it was mostly women of color who were serving as midwives and immigrant women. And so physicians who at that time were mostly landowning, wealthy white men were like, hey, don't get care with midwives. Midwives are dirty. They're unhygienic. You're going to get an infection. Have a physician instead. And so even though really almost all the births at that time were home births and cared for by midwives, there was a push to replace midwifery with this sort of clean, sanitary medical model. And then around the time that, I think it was in the 1920s, smallpox outbreak was eradicated, hospitals suddenly had a lot of empty beds. And that's when there was really a move towards having hospital-based birth. So physicians then really started advertising the hospital as the best place to give birth for everybody rather than home birth. And again, it was really a campaign that was based in white supremacy as well as classism of only poor people and dirty people gave birth at home. And if you were someone of class and if you were someone of means, you would give birth in a hospital. And so it was less about a medical reason or outcomes. And in fact, in the beginning, there were actually way worse outcomes with physicians and hospital births than with home births and midwives for, the limited data that we have. But it was really an intentional campaign to try to eradicate the competition of midwives. And so then it wasn't until like the 1960s and the 1970s that midwives kind of became a little bit more mainstream. And it wasn't, I feel like mainstream is even an exaggeration because I feel like even now I'm not sure if you could say midwives are mainstream, but in the 1960s and the 1970s, at least in like white America, midwifery and a more natural birth movement began to gain a lot of traction. A lot of people talk about Ina May Gaskin, which is maybe one of the people that you were referring to, as is sometimes named as like the mother or grandmother of midwifery in the United States. But I really think it's important to name that there were lots of people who were practicing midwifery and caring for pregnant people for millennia beforehand. And Ina May Gaskin was part of a troop of hippies who traveled from California to Tennessee and converted school buses and started an intentional community in Tennessee called The Farm, where they really were largely self-taught, although they did work closely with a local obstetrician to learn how to care for each other in pregnancy and in birth, and gave birth on the buses and then at their intentional community in Tennessee. And The Farm has really developed into this kind of, it's known as being this like center now for folks to go and train for out of hospital birth, and where really out of hospital birth was sort of popularized, at least amongst in a more mainstream and white centered American population.
Yeah. Have you ever visited the farm yourself?
I haven't. I worked as a doula before I became a midwife, and partly because I didn't know whether I wanted to be a midwife or an OBGYN, whether I wanted to be based in the hospital or out of hospital for birth. I knew I wanted to work in birth, but I wanted to sort of observe a lot of different types of birth and care models to choose which one felt most aligned with what I wanted my work to look like. And I feel like as a doula, I definitely fangirled a little bit about the idea of having this like community that was really devoted to supporting normal physiological birth. And they do offer trainings, but there's also so many resources for midwifery training and for natural physiological birth that, again, it's really funny to say like pop culture recognition, because I think most people don't know about the farm. I think that there's a lot of cool places where people can learn about birth and normal physiological birth, including out of birth hospital birth centers that maybe serve different communities than the farm does. My dental hygienist was born and grew up at the farm. And so every time I go to get my teeth cleaned, we just talk about birth the whole time because she grew up in that community.
Yeah. Wow. That's pretty unique. Actually, that's pretty special, and maybe is a fun way to just get through a teeth cleaning. I was saying earlier, tell us more about your decision to become a midwife. I think, alluded to the fact that you used your role as a doula to help you kind of navigate what space you wanted to be in, but you had obviously some probably very impactful and probably emotionally taxing work you did as a domestic violence counselor and rape crisis counselor. How did you make that transition?
Thank you for asking. So I actually went back to school to get a second bachelor's degree in nursing to become a midwife. Before that, I had actually graduated from a liberal arts college with a political science degree with this plan to become a lawyer. I wanted to work as a lawyer. I wanted to work with human rights and specifically around reproductive rights and women's health issues. That's when I worked at the district attorney's office in the DV bureau. I had an internship over the summer, and that's when I saw kind of day to day what the work actually was. And over the course of a summer, I was like, I don't think this is for me. I don't think this is actually what I can do on a day-to-day level and feel like I'm making the impact I want to make. And so I really had to take a step back and think, what is it that I want to do to have the impact that I want? What do I want my day-to-day life to look like? Because until you actually do a job, you don't necessarily know what it's like. And that's true for healthcare as well. I think we all grow up with the idea of what is a doctor or what is a nurse. And then until you're actually doing the work and training to do that work, you don't really even understand what the full scope is, let alone what your daily schedule or weekly schedule looks like. And so I wanted to make sure that I had an opportunity to really exist in the space that I would be working with to know that it was the right fit for me. And so I really was thinking about what was it about women's health and reproductive rights that made me feel so passionate. And I realized that a lot of the work I was doing as a rape crisis counselor and domestic violence counselor, I was trying to heal this wound that was created by trauma and by violence against women. And it's intentionally gendered violence against women or against people who are assigned female at birth and women. I was coming in after the trauma had occurred to try to help facilitate healing. And it was around this time that I was thinking, what am I going to do with my life that I can kind of continue to do this work, that the first of my friends became pregnant. And she was live journaling a lot about her pregnancy and prenatal care. So that will date myself to that. I was reading, every week she had a few posts about her pregnancy and her prenatal care experience and her birth plan. And I specifically remember reading about her desire to avoid an episiotomy. And at this point, I was in my early 20s and I was like, what's an episiotomy? And so for those who don't know who are listening, an episiotomy is when we make a small incision in the vagina, really like at the vaginal opening, to slightly enlarge the vaginal opening to facilitate a faster delivery. And these days it's really done so rarely. But I would even say that at this time when I was thinking about, this was only about probably 16, 17, 18 years ago that I was having these thoughts and reading about it, it wasn't so rare. And there's even places in Northern California that still have really high episiotomy rates. And I remember learning about episiotomies and just thinking this is violence. This is gendered violence. This is violence of a sexual nature. It's obstetric violence. And while there's medical justification for it, often, although when you look historically, you find that throughout the 1970s and 80s, the general thought was that every first baby should be delivered with an episiotomy because otherwise there would be brain damage because the birth canal was too narrow for first babies. I remember reading this and thinking this is you're literally cutting someone's really important, sensitive, vital tissue. And I had this realization that birth was a time where there was the potential for tremendous trauma to occur. And by working in birth, I had the potential to, as an individual clinician, actually prevent trauma from happening. And the best case scenario being that rather than birth being a traumatic experience for people, I could help support an experience that could actually be incredibly empowering for people, to help people feel empowered and strong and brave and autonomous and really in touch with their body. And I do think that that's absolutely possible with the right prenatal care and birth care, with the right support. And so that's my goal every time that I care for someone, every time that I'm at a birth, is how do we prevent trauma? How do we prevent violence? Which is partly just an unfortunate, sometimes intentional result of the system that has been built and created in the United States in particular around obstetric care. When you look at the legacy of who developed obstetric care in the United States and why, that it was, not intended for as a way to support and empower people, but really intended for profit. That we, as the clinicians and the birth workers who choose to be in this field, have such a duty to undo that legacy. And we have our work cut out for us.
Yeah.
I'm getting like goosebumps just thinking about it.
Yeah, no, I mean, so beautifully said. And I think so much of the work that you do is work that makes patients feel so empowered and hopefully safe. I think it's not uncommon for patients to come into that first prenatal appointment with fear, right? Oftentimes that fear comes from like birth trauma from a prior experience, but especially for our first time patients, sometimes they just hear things, they read things, they hear about the things that the healthcare system does to their bodies, not with them, not in support of them, not in conjunction with them, but to them, that they come already kind of like dukes up, like, hey, what do I have to do to like combat this?
Right. And when you think about how birth is portrayed in movies and TV shows, it's always this super stressful, traumatic event. Like I remember TLC's A Baby Story. It's like every birth is an emergency C-section. Yeah. And I think that was one of the things I love about the show called The Midwife, is that they have emergencies on the show, but they're either emergencies or they're just, non-ideal outcomes that happen. But the midwives are like, hey, so your baby's breech, but rather than it being like the Grey's Anatomy stat C-section in a kitchen with a kitchen knife and hand sanitizer for a first-time mom, where it's like, you could walk to the hospital in time. What are you doing? Yeah. But rather than that, the midwife is like, but I'm a skilled, trained birth professional. This is literally my job. I've got you. I've got your baby. I'm going to take care of you like I know how to. And it's not a big deal and it's not stressful at all. And so far less adrenaline watching Call the Midwife, but I'm like, that's what it's actually like. We are trained professionals. We know how to take care of you. Yeah. How do you create that sense of sanctity and safety in those first couple of visits? What is it that you say? How do you kind of help patients realize, hey, you don't need to come into this room on the defensive. Like we're here for you. We've got you. Oh my gosh, that's such a good question. And I would love to hear what absolutely everyone has to say and what our patients say about this. I also love in particular that you're using the word safety, because I think that's the counter to trauma. That's the counter to violence, right? Is safety and support. And so that absolutely has to be the focus of how do we make people feel safe? I think a huge part of it is acknowledging the power dynamic in the room, right? Anytime someone comes into the clinic, that in of itself is a power dynamic where you are leaving your home and you are going into a space where the healthcare system, where the clinician kind of has the institutional power and you as a patient are kind of this like moving through the system that was in some ways, I think, intentionally designed to sort of create like a even playing field for folks. But in reality, it's not an even playing field. Like people are not coming in. In reality, it's not an even playing field. People come in with their lived experiences, with their family, with their community, with where they live, with how they're living, with so much more that makes them who they are. And in some ways, I feel like the medical clinic is designed to strip that away from them. And so I think that really our job as clinicians and as midwives are really trained to dig into figuring out, like identifying who people are, what are the concerns and preferences that they're coming in with, and so that we can help take care of them as a person within this larger context of who they are. Like we always talk about meeting people where they are as patients. And so getting to know people from the beginning, getting to know their concerns, but I think also with acknowledging that power shift, or rather with acknowledging that power dynamic, a lot of it is just the language we use. And so anytime that patients ask me questions like, well, am I allowed to push in different positions? I'll say like, you are allowing us to care for you. That is the only allowing that's happening. Like, you are letting me be present at this really important event. And so you are allowed to do whatever you want with your body. Like, it is, there might be medical reasons why we might make certain recommendations, but my role here is to explain the recommendations. And then you have the much harder job of deciding if you're going to accept that recommendation or not. If this recommendation is relevant to you, to consider the way that you do risk calculations. I think COVID sort of showed us, those of us who work in obstetrics, what we've experienced for a really long time is that different people calculate risk differently. And that probably you as an individual can think of a time how your risk assessment around COVID really changed over time based on what data is available, what research was actually done, what was happening to the people who were close to you, to your friends and family. So like more anecdotal experiences. And then also just how you felt on any given day when you woke up of like, is this a risk that was willing to take or not? And I think that that's also something that really needs to be acknowledged in obstetric care and maternity care and in birth, that the perspective that maybe clinicians come in with is based on population level risk and population level guidelines and advice. And so how do we help translate that for people to make an individual assessment about their own bodies and about their own experiences? That's
so well said. What I appreciate about the collaborative practice that you and I both work in is that not only is there a different approach to how maybe I, as an obstetrician, go into a prenatal visit versus you, there's also time.
Yes.
This is kind of a continuous theme throughout various podcast episodes, but the healthcare system that we are in is constrained and imperfect and broken. And so when I hear you, I'm like, but I only have 10 minutes.
Right.
How do I do that in 10 minutes? Do you find that there's a continuum for you in terms of, encouraging patients that you are simply the support person, that they actually have the locus of control as much as anyone really can? Right. Is it something that you kind of hone in at the very first visit, or do you kind of take your time and sprinkle those affirmations throughout their prenatal care? That's such an important point, is that the healthcare system really is not designed for empowering relationships, right? Which is, I think, why home birth providers or out of hospital providers really have an advantage of, 40-minute, 2-hour-long prenatal appointments. It's a different system. And so for people that is available to them, that is a very different experience. But for folks who are either choosing to get kind of like this traditional healthcare model, it's tough. It's, as I said, our work is cut out for us. When you said like, well, how do you do it in 10 minutes? I would say the answer is very intentionally, right? Like every single conversation is an opportunity for folks to kind of consider or maybe reconsider their approach and unlearn some of the fear and trauma that you've probably have internalized your entire life around pregnancy. Every time an opportunity comes up to talk about anything, like sometimes people will ask questions about like, oh, well, is X safe in pregnancy? It would be so easy to just be like, yeah, that's fine. But instead, I try to take a step back and talk about, well, why would we be concerned about this? And how do you then decide if this is something that you feel comfortable doing or not? So often people will talk about like, oh, well, is it safe to travel in pregnancy? I'm planning a baby moon. And so rather than just saying like, oh yeah, it should be fine for you to do that. Or, oh, actually, we don't recommend traveling after 36 weeks or something like that. I take a step back and say like, wow, that sounds really fun. Tell me about this. Or maybe it's not fun, actually. Maybe someone's traveling for a funeral, right? And so how do you actually individualize the situation and talk about like, what are the benefits of going? What are the risks of going? What are the concerns about travel? How would you feel if those risks actually happen? Like, what if you were traveling somewhere and you needed hospital level care? How would you feel about that? And so I think it's really easy to have either a cookie cutter approach or a very efficient approach of just saying yes and no to people. But it's kind of the difference between like giving someone a fish versus teaching them to fish. And so having really conversations about how are you going to make this decision, I think is not only so important for helping shift the power dynamic that exists in healthcare as like us as the holders of power, and really acknowledging and recognizing that the people we care for are the experts in their bodies and the experts in their lives and the experts in how they perceive risk. But like, for example, I had one patient who had a placenta previa who wanted to travel to Europe for like a month for like near the like late second trimester, early third trimester for pregnancy. The catch was she herself was from Europe. She herself had family that she was going to visit. Yeah. And so when we talked about it, she's like, honestly, if I start bleeding and I need to be hospitalized,
I would rather do that in my home country with my family to support me. If I end up having an emergency preterm delivery, I will be more supported if that happens while I'm visiting my family than here in California, where I am a single mom by choice. And so you know what? That is an acceptable risk for me. I'm going to go and travel and spend a month there and understand that there's risks, understand I might need hospital level care, but I'm also really comfortable with the type of care that I would receive in that country. They have excellent maternal health outcomes in that country, probably better than the US.
Yeah. I think everyone is better than us.
Right.
No, that's so well said, that everything has to be contextualized, right? That there are those textbook answers that we've all been trained to memorize, and time constraints and for the sake of efficiency, we can spew them out quite well. But if you're able to reframe it around the patient, right, that everything should be as patient-centric as possible. We are just the tools here to serve those patients. And so if you can take each thing that they bring up, like contextualize and framed around them, you can still do it somewhat efficiently, but you can do it in a way that makes that patient hopefully feel like it's not just a statement that you say to everyone else. It's like, it's about them. It's like, oh, you have family in Europe. This makes sense. Like if something acutely happens, you actually can have the care and support that you need. Yeah, I love it. One of the jokes that, I make with you is that you have all these Martina-isms that I like to like pick up and instill, and you put it as part of my vocabulary. And there's a lot of isms in my mind now, a lot of things I'm going to say thanks to you. So I'm so grateful. Something I think about a lot, and some of my frustration, to be frank, as an obstetrician MD in our constrained and broken healthcare system, is I don't feel like I can be the best clinician I know I can be in those time constraints, right? And there's something that has to happen at a systemic level, way bigger than us, way above our pay grade to change. And I've found that something that like brings me to my happy place and where I can like have the space to practice the way I want is centering.
Yeah.
Do you mind telling the audience more about what centering in pregnancy is?
Absolutely. And actually, as I was giving that example, I was thinking this is what we do in centering. Centering is such a good example of that. So centering pregnancy is a form of group prenatal care that was actually developed by a midwife. And I think midwives and nurses who really shaped it. So it's group prenatal care. So rather than having an individual appointment that might be 10, 15, 20 minutes long, you have a much longer appointment that's usually 1.5, 2 hours long, in a group of other pregnant people who are at the same who are at the same stage of gestation as you. So in our practice, we do it based on due months. So right now I'm leading the November due dates group. And so everyone in my group, there's about 12 people who are all due in November. In every session, there's still some one-on-one time where I measure their belly, listen to baby's heartbeat, but the rest of the session is done in group. People take their own vital signs when they arrive. So they take their own blood pressure, they take their own weight and record it. Then we have so much more time for, first of all, socializing and creating community, and also really doing a deep dive into the questions and concerns that people really have. Every one of our sessions has a theme. And so we'll talk about like the do's and don'ts of pregnancy, which is probably my favorite thing to talk about. As you can probably tell, we talk about breastfeeding or body feeding. We talk about newborn care. We talk about labor. We talk about birth. We talk about the postpartum period. And even those 2 hour sessions don't feel long enough to me. And so I really think that those sessions are appointments. The purpose of them is to really start the conversation, plant some questions so that people can answer the questions for themselves and figure it out for themselves. It's often like writing your birth preferences or writing your birth plan. It's not homework. You get your baby whether you do it or not, but it's the study guide, right? The work is actually you reading through it, making decisions about your care and your birth and what you want your birth to look like. So the first session of centering, we talk about a lot about the do's and don'ts of pregnancy. And so that's often when these kind of questions come up, like, oh, well, is it safe to eat sushi in pregnancy? And so I think that it's so important to not just give an answer, but really kind of talk about like, well, what's our concern with sushi? And so the two big things that people talk about are food poisoning and mercury. Okay, well, how do we know if a fish has a lot of mercury? Turns out that the Fish and Wildlife Department actually publishes a list every year of what fish have the highest mercury. And the mercury levels that we're concerned with on most years are whale, shark, king mackerel, and tilefish. So if people are not eating those 4 fish, we're really not that worried about mercury in fish. You would have to eat lots and 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 lots of fish to really have a dangerous level of mercury that would be considered unsafe in pregnancy. Okay, so that is maybe something we don't have to be as worried about. Well, then food poisoning. Why are we worried about food poisoning in pregnancy? And then we talk about what's the actual risk of getting food poisoning from any particular food. And so if you're getting commercially made sushi in a restaurant that's being regulated by the Department of Sanitation and has like an A grade on the wall, you've been eating there for 10 years, you've never gotten food poisoning. What is the risk of getting food poisoning? It's not 0%, but it's probably really low. And then what's the benefit of eating sushi? The benefit of eating sushi is that there's actually, like, we know that those omegas and the DHA actually really help with fetal brain development. So it might actually be better for you to eat sushi when you're pregnant than not. So why are we focusing so much about the danger, the risk? And so you mentioned this earlier about like the fear that exists in our society around pregnancy. And I think a lot of that fear is actually based in misogyny as well. I think that fear is based on really only seeing and valuing women as like vessels of reproduction. And so when we love like, you're pregnant now, you have to think about risk differently. And I think that is true for a lot of people, that when they're pregnant, they think about risk differently. But really thinking about like a larger context of like, what's the actual risk? What's the benefit of this? What's the benefit of going to see your family? And so I think it's so important to have those conversations in that way, because this is actually a skill that people will use, not just throughout their whole pregnancy, but then making medical decisions if they come up in birth, right? How do you make decisions about your care when there's multiple medically appropriate options, or when a medical recommendation or when a medical intervention is recommended? How do you make that decision? When you're parenting, there's no universally right way to take care of your baby and raise a child so that they are like a good, well-rounded person. So how do you make decisions for your family when there's no clear, obvious right or wrong answer? How do you make decisions that are best for your family? So I really think that we as healthcare clinicians have like a duty to really try to usurp that dynamic and flip the script on who actually has the right answers, because this is helping our patients feel empowered to then continue to make those decisions for the rest of their lives as parents, as well as people with bodies who need medical decisions, of how do you feel good in the choices that you make?
Yeah.
Or how do you feel good about how you make those choices?
Yeah. When I have a good centering session is when I speak the least, right?
Yes.
Where if there's a question that we have something in centering called the container. So that's when patients will put like any question that they've had since the last session up there. My goal always is to have the patients answer the container questions themselves, or explore more like why they asked that question. I feel so different when I'm in centering, in that there's a huge dynamic shift. Like I feel like more of a passive participant. Like I can sit back and watch this amazing group of people kind of bond and educate one another, rather than me kind of inserting myself. And it's a nice break personally, but also just feels so enriching. You see these connections being made. You see patients like be pleasantly surprised by the fact that they're a resource. Like, I just happened to read that and they didn't know that. Great. Like it makes them feel excited. And you can see like that physical body shift when you realize, hey, I was able to teach something to someone else.
Right. That there's so much expertise that already exists in that community. Yeah.
Yeah. I love centering. I think you do too, because we are very biased as being centering facilitators. Who would you recommend centering to? Who maybe is centering not the best fit for?
Well, and thank you for bringing me back to centering, because I started going off on a rant there, as I usually do. But I think they're tied together. It's why I love centering so much.
It's all connected.
One of the things that I think is so magical about centering, like we talk about how fun it is, we talk about what an amazing resource it is, but there's actually really amazing data about centering pregnancy as group prenatal care in particular, that I think is really important to consider when you're thinking about who centering is best for. My short answer is everybody. And I think everybody should do centering, because it's actually been shown to reduce rates of preterm birth and low birth weight babies, and to reduce race-based health disparities in prenatal care, because everybody's getting the same care. So you're removing a lot of implicit bias and provider bias, the institutional racism that exists, because everybody's getting the same care. And so for those reasons, I think everybody should be doing centering pregnancy or group prenatal care. For babies that are born preterm, of moms who do centering, of pregnant people who do centering, they tend to stay pregnant for, I think it's 3 weeks longer, and weigh 1 pound on average more than like the average preterm baby. So even for folks who do end up delivering preterm, participating in centering has such a protective effect. So there's something that's just absolutely magical about being in community when you're pregnant. And so I think everybody should be in community when they're pregnant. I guess like if someone already has a great community where they're already surrounded by other pregnant people, then they've got that covered. But I think for most people, we are far more isolated now than, we were probably in ages past when we were all constantly either pregnant or postpartum and only lived to be 35. So everybody was constantly in group prenatal care. But I think it can be such a benefit for everybody. And because it's a group, if you have a skilled facilitator such as yourself, then you'll have, it's appropriate and okay for people who feel like a little bit more introverted and quiet, because you still get to benefit from other people's questions. And we come up with activities where people can participate in different ways. I think it can be fun for everybody and great for everybody. I think that I have a different spiel depending on who I'm trying to recruit. I think for first-time moms, it could be so helpful because you get so much more information. But I think for people who are second-time parents or third-time parents, it's actually also really important, because when you're pregnant with your first kiddo, you are constantly thinking about that baby. You're thinking about this pregnancy. You're thinking about this baby. You're thinking about them all the time. You're like, anytime you're not actively doing something else, you're getting ready for this baby. And then that baby's born. And then if you're pregnant with a second baby, you're thinking about that baby that was born. You're thinking about that first baby, because then they are here and they are needy and they need your attention and resources, right? And so having a longer prenatal appointment, like a group session, is actually a really wonderful time to have a protected part of time that's like a longer period of time that you can really think about this baby and think about this pregnancy and get ready for this birth, because the rest of the time you are living your life and you're taking care of that baby that's already been born, that's running around.
Yeah. That's great. You are a very effective recruit. I've been recruited. I want to do Century. I've been recruited. So I'd like to take a moment to tell you this is my passion project based on years of experience as an OB/GYN doctor. I aim to empower moms and moms-to-be and those in the pregnancy and postpartum care space. If you appreciate what I do, please take a moment to like, subscribe, and share with your friends so it can reach more people like you. You can visit goldenhour.fm for more information, resources, and all other episodes. If you have any requests, suggestions, or questions for future episodes, please email me at hello@goldenhour.fm or leave us a comment at goldenhour.fm on Instagram. Something that you mentioned earlier that you did before you became this highly amazing midwife was being a doula. Can you tell us more about what a doula is in case people don't know?
Definitely. And I think this is another thing that people get doulas and midwives confused. So midwives are medical professionals. We are clinicians. We are trained to provide medical care for you and your baby. And so that is the perspective that we have when we care for people in pregnancy and birth. Doulas are non-medical professionals. They're non-medical support people. One quick way of thinking about it is a doula should never do anything that requires them to put on gloves. And I thought that was really well said. So doulas can provide physical support, emotional support, informational support to pregnant people and their families throughout pregnancy, labor, birth, the postpartum period. There's also postpartum doulas that specialize in helping care for families and the people who've given birth after they give birth, postpartum. So usually those doulas will come to your home and kind of take care of you so that you can take care of your baby. So that's different than like a nanny or a baby nurse. There's also abortion doulas that help support people through abortions. There's death doulas. There's a lot of different types of doulas that really the role of a doula is to provide support and kind of shepherd people through transitional experiences or through significant experiences. And so I love being a birth doula because you really are super, super focused on the people who you're taking care of in a way that isn't possible in a healthcare model for me as a midwife. As a midwife, I'm taking care of the people I'm taking care of, and it's the people I'm taking care of, right? So when I see someone in clinic, I see, on average, like 17, 18 people a day in clinic. And so I try to be as present as possible during those appointments. But there's a system that you've talked about already that we're really constrained by, whether it's time or space, there's a system. But in labor, it's how many people do I have in labor at any given time? And how do I balance the needs of everybody as I take care of them? How do I really prioritize the medical care in that context? But a doula can be really, really focused on just the person that they are with and the person that they're caring for. And that continuity of care is also really magical. The evidence about doulas is consistently positive. So doulas have been shown to decrease C-section rates, shorten the length of labor, decrease epidural use, and increase positive experience of labor and birth. Having a doula has been shown in the research to be more effective than having a family member present and more effective than having a partner present in all of those metrics except for satisfaction. So people will work kind of equal patient experience, patient satisfaction, whether it's a family member, friend, partner, or doula. But in terms of reducing length of labor, reducing C-sections, reducing epidural use, and increasing breastfeeding rates, that's only been shown by having a doula, that continuous labor support.
Yeah, that's pretty powerful. I think when someone comes in and asks me, like, should I get a doula? What are the benefits? I think you summarize it quite well. And I think some of it comes from what you alluded to earlier, right? There's something so naturally more isolating about the world that we live in now that hundreds of years ago, units were multi-generational. Because of resources and because of geography, you really kind of lived on a piece of land with many other people in your family, aunts, cousins, etc., and that support was built in.
Yeah.
And then as time has gone and made all these technological advancements, there's a lot more individualism in society. And I'm not saying that that's wrong, but I also have found that people seem a lot more lonely.
Yeah.
There's a lot more, couples, or even for patients who choose to be single parents by choice, who are alone and then have to kind of then rebuild community. And sometimes that community can come in centering. Sometimes that additional support can come from a doula. Sometimes I think about whether or not these are very helpful solutions to like societal changes. And I don't know if there's like an answer to that versus me just like pondering it right now as we speak. That
I think it's an answer to the structural challenges that exist in the system of healthcare, right? Like it would be wonderful for us to have 2-hour prenatal sessions, but in the system as it exists, that doesn't happen. So how can we plant a seed that then someone's community can help support? Earlier, I was talking about how it's not my job to make people's decisions for them. It's my job to explain the decision that needs to be made and then give them the information, resources for them to make that decision. So often I feel like that's where a doula is really great, is I go in and I say, hey, here's the situation. Here's the medical decision that needs to be made. Here's my recommendation. And then I can step out of the space and my patient can confirm with her doula to figure out, okay, like, well, what are we concerned about? The midwife outlined what we're concerned about. What are the benefits of the interventions? The midwife outlined that. The risks are, the midwife outlined that. But now I have to make the decision about if these benefits are worth these risks for me. And that's where I think a doula as a non-medical provider can actually be really helpful, because that's not then a medical decision or a medical recommendation. It's about making a personalized, individualized choice for someone. And I feel like that's where birth doulas in particular can be really helpful, is sort of helping translate the decision that needs to be made so that it's relevant to the person who's making the decision, or like helping them kind of navigate that decision. When I worked as a doula, that was a lot of what I did in terms of informational support. Was sometimes clinicians in the systems that people were giving birth in didn't even have time to go through the benefits, risks, and alternatives. They would come in and say, hey, I think we should start Pitocin, and then walk out of the room. And sometimes talk about why and sometimes not. At that point, I was, trained and skilled in like, what's Pitocin? What does it do? And then we could talk about it. And then people could decide if that was right for them at that time. And I think that's the other piece, is at that time, right? Like labor is not a 30-second experience like it is in the movies. So if there's a situation where labor is taking a really long time, there's often a lot of opportunities to change course. And so having someone who's been through it before is really helpful. And I think, as you said, like previously, when we were living in these more community-based communities, we were constantly seeing birth. We would see our siblings be born. We were seeing our friends give birth, our cousins give birth, our neighbors give birth. We would see everybody feeding their babies. And we don't see that anymore. We only see it in this really dramatized, usually increased danger situation, fear-based, situation of TV and movies. And so how do we actually learn about what's happening to our bodies?
Yeah. Something that you said earlier was that you theorize that a lot of this like fear comes from misogyny, comes from, inaccurate portrayals in TV and movies. Any other thought of, again, there's this, and you said it before, that midwives, because you are so well trained in normal physiologic pregnancy, birth, gynecologic care, that sometimes it can seem those on the MD side of things maybe are quick to pathologize. But I find that I say the opposite. I often say that I don't pathologize care, that I think that most of the processes that the human body does is actually normal and natural. And I'm only here for those like the more rare things that need some sort of medical intervention, whether it's medication or procedure. And that's also because, plug here, I was trained by midwives and they're awesome. But that being said, I do find that oftentimes patients come into a room saying, something's wrong with me. What's wrong with me? Help me find what's wrong with me.
Yeah.
Or for when it comes to obstetrics, it's like, well, I've heard all these bad things are going to happen. How do I make sure those bad things don't happen to me? What else do you think has contributed to those notions?
Ooh, that's such a big question. And I also want to acknowledge what you said about when people come in and say, hey, something's wrong, how it's so important to listen to them.
Yeah.
Because I think also as much as I'm talking about how pregnancy is normal and pregnancy is physiological and normal physiological health, I don't ever want to be so focused on everything is normal that I'm dismissive of patient concerns. Mm-hmm. And I think sometimes there's an opportunity for context. And I think this is actually where centering can be really helpful, is when people come in and say, oh my gosh, I'm having, my feet are swollen. Does this mean I have preeclampsia at 16 weeks? And a lot of fear around that. But then when you're in community and everyone else in the room is like, oh yeah, I also have, I'm also crazy constipated, whatever it is. I also have really painful hemorrhoids, to really normalize the experience. I think that's when community can be really helpful for context of how worried should someone be. So that's another plug for centering of really kind of being able to pool your experiences and kind of have the context for what's normal, but then also crowdsource solutions for it of what are you doing for constipation? Oh, this tea is really great. I like this flavor in particular, Smooth Move. I just learned from one of my centering patients, they make a chocolate Smooth Move tea for constipation. So
okay.
If you're looking for a sponsorship. I think that's a tangent on a tangent there. But yeah, so why community is so important, why context is so important for knowing. But I think context as clinicians, and I think this is something that maybe midwives do in a different way, is that because we train to specialize in normal, we tend to take care of low and maybe medium risk patients. At least this is what's intended, right, in our training and our practice. And I think in looking at the healthcare system, it maybe changed a little bit, and we're taking care of more high-risk patients in most settings. But at least the intention in the training for midwives is, when you're looking at the context of low-risk people, you are going to have an appropriate assessment for what is normal and what is common. And then you're going to have a certain set of expectations for outcomes based on the population of people that you care for. And being an expert in normal does not mean that you then assume everything's normal. It means that you actually are really good at identifying when something is not normal. It means that as an expert in normal, I am used to taking care of well people, and I can identify if someone is not well and then needs a different level of care. I think that because of that, I have certain expectations about what outcomes are expected based on how normal, well people are, as their pregnancy is developing and as their labor is developing. And so that shifts my perspective of my expectations of outcomes. And so to sort of give an example of if I am taking care of someone who is normal and healthy, whose labor is progressing in the way I would expect, and I look at their fetal heart rate tracing and I'm noticing decels, I'm going to think about it in that context of the rest of their pregnancy. And in the context of my expectations from my personal experience of caring for this population. And I think that means that I might have a different interpretation and a different anticipation of risk than someone who's an expert in taking care of higher risk patients that are more likely to have a bad outcome. If you are trained and if you are used to taking care of high risk patients, you are going to see statistically a higher rate of scary outcomes. And so you have to think about those outcomes to best care for your patients and ensure that they stay safe and stay healthy and that their babies are safe and healthy. But because of that, we could be looking at the same exact strip and have different contexts and have different expectations. And therefore, our own personal fear meter, our own personal risk assessment might be going off differently. And that's why that context is so important, of both understanding what is the context that this person who's in labor is going through, what's the context that they bring, but also what's the context of my expectations based on who I'm caring for. And I think that can start to sort of get muddied and diluted as a midwife who's taking care of a higher risk population, because I'm seeing more bad outcomes, because statistically that's where you would expect more bad outcomes with a high risk population. But there has to be a different perspective. There has to be a different set of expectations based on who you're used to caring for. Because we talk a lot about population-based risk, and it's why we make different recommendations if someone is over 40 than if they're 35 or if they're 25, right? Because we have data set on the population that they are part of. So if you as a clinician are only taking care of a certain subset of the population, and so it doesn't, when I say high risk, it can mean a lot of different things, but I think it's really important for us to individualize the people we care for, but also contextualize who we're caring for. And so that is going to look very different based on the hospital you work in, based on the community you care for, based on where you're practicing and the culture, the obstetric culture of where in the country or where in the world you're practicing. So it's a really indirect way to sort of answer that question of like, what else is feeding into that fear? But I think as a clinician, we have a responsibility of like, what is the bias that we're bringing into the space in terms of my fear, in terms of the bad outcomes that I've witnessed? How am I contextualizing those? Are those something that are common occurrence? Are those something that are zebra? How much of my own fear as a clinician am I bringing into the space as I am making recommendations for the person who I'm caring for? And there's no neat answer for that.
No. Despite that, you still said it so eloquently. I mean, there's so much complexity to caring for people. I mean, I say this often. It is incredibly humbling to be a human caring for other humans, right? Because not only do the humans that we care for come into that space with their own appropriate layers, but we do too. We've seen things, and I'm acutely aware, especially as an obstetrician, because I get tagged in at the most high risk times, you know.
You're literally a lifesaver.
Thanks. But I come in and I've seen so much. And I always have to pause and recognize in those moments, like, hey, I am coming in with my own unintended bias of fear, because I'm more scared of the very rare things that I've seen in my career.
Because they're less rare for you. Like, they are going to be rare for me if I specialize in normal well pregnancy. But as someone who has a more specialized skill set where you see the scary stuff because you care for people who have a higher level of need, because you specialize in that this is, I need to pause for a minute, because I'm like in awe of you, like working. I think this is one of the things that happens working with physicians is like you guys are such badasses all the time, and you literally come in and save the day. But that perspective, it's sort of this, like, if the only tool you have is a hammer, right? Like, if as an obstetrician, you can do a C-section, you're going to think very differently about doing C-sections than when I'm like, wait, I need to call someone in to do it. So I'm not going to do it unless I really have to. And that's a way oversimplification of the idea. But I think, again, it has to do with like, what's the perspective we bring in, and like why they're both so important. Yeah. And in some ways why I think it's not that I want us to like stay in our lanes, but I think like understanding like where we specialize and understanding the perspective we bring in is so important.
I've had the honor of, I was trained in a collaborative setting. I then worked in our current care setting when we didn't have midwives, and now have since been practicing for several years back in a collaborative setting. And so I truly, deeply believe, I'm going to give you props back, that I'm a better clinician now because you guys are around. By you guys, I mean midwives, because it does allow us to like hone in on our expertise while you both hone in on your expertise, and then the collaboration that we're able to do together. Right. The best feeling is that feeling when there is this, we often use this phrase in medicine, but like the warm handoff, when we together are coming together to care for that patient. Whenever what was normal and physiologic takes the turn to something that's more high risk and needs our intervention, and we can meet them there. I'm very biased. I so love collaborative practice, again, because that's what I was trained to do. And that's what I'm currently working in. And I feel like I'm working at my maximum potential as a clinician because of it. But there are so many different ways to give birth and to be supported in different settings, whether it's hospital-based or birth center or home birth. I think what you've alluded to, that one of the cons, because, it's good to be honest, one of the cons about being in a collaborative practice is that we both function in a hospital-based collaborative practice. I think something that was really interesting to me that you taught me was that home births have had a journey of their own, right? That there was a time when home births were purposely depicted as like dirty, only for the poor, only for, the immigrants, only for the enslaved, just really kind of put down. And then we have this interesting swing now where home births, because it tends to not be covered by insurance, is actually an experience of privilege. Do you have any thoughts about that?
Yes, I have so many thoughts about that. And I was actually going to say something about out-of-hospital births, so I'm so glad that you did. I think it's also a lot of Black and brown people and queer people and gender nonconforming people are specifically seeking out-of-hospital birth. You're less likely to experience the white supremacy, the racism, the heterosexism and heteronormativity, the homophobia that happens in hospital spaces and medical spaces because of the way they're designed and because of the way that bias is perpetuated. So I think that's one of the huge, speaking of perspectives and the perspective that we bring in and kind of the population specific perspectives that we bring to birth and to other medical contexts, I think that's also where out of hospital and community birth, like home birth and birth center clinicians or providers can really specialize is you're seeing people who are incredibly low risk. Anyone who has a medical reason or who has a risk criteria to have a hospital-based birth has risked out of that model of care. So you're only caring for the lowest risk population, the people who are normal, the people who are well. And therefore, the outcomes that you're going to see are statistically the best of the best. And I think that's actually a really important perspective. And I think that often as hospital-based providers, we have a lot of fear around community birth because we're like, well, what about the bad things that can happen? And we actually have data about like, what are the statistics? Like what's the actual occurrence of those bad things happening, not for a general population, but specifically for the lowest risk population. And it really, truly is outstandingly low. And so how do we make a decision about that? How do we shift our perspective and our fear around that? And so I think that people who choose to give birth in a community-based setting get to really reap the benefits of that, is that they're going to have a provider taking care of them. They're going to have a clinician, usually a midwife or taking care of them, who has that perspective of normal, who has the expectations of normal, and therefore also has the skill set of identifying when things are straying from normal, and then can identify like, hey, actually, I think the better place for you to be cared for might be in a hospital setting. That's their specialty, is really knowing how to care for people who, with that perspective, with a lot of that fear themselves removed. Also, you're caring for people who have made autonomous choice. Like, I don't think people just choose to give birth because of like, oh, I saw it on TikTok, right? Like they choose to give birth in a community setting because it's something that people have thought about a lot. And it's informed by their belief about themselves and their body and their autonomy and the way they think of risk. And it's really important that you choose the right provider for you, the right clinician for you. Yeah. And that's part of the experience of giving birth in a community setting, is someone who's an expert in that. And then also someone who has a certain set of skills and tools to support that happening. So for example, in a hospital, if someone's labor is stalling, we have medications. So we can say, oh, well, we can try this medication or that medication because we have it. And you don't have those medications available in a birth center or in a home setting, in a community setting. And so instead you have to look for other skills. And so you might say, here's certain positions that we can try. Here's certain activities. Here's certain body mechanical things you can do. Here's certain herbs. Here's certain supplements. Here's homeopathy. Here's traditional Chinese medicine. Here's acupuncture. Like, here are the other skills and resources that those out of hospital clinicians might have to help move things along.
I have to ask it because obviously there are so many pros to having an out of hospital birth for the things that you already named, especially for certain more marginalized communities. Thanks for that call out. Not only just those who are privileged based on their financial well-being. How come you are not practicing in a community-based birth setting? What informed your decision? You know, we know a lot about you now. We understand how you ended up choosing to become a midwife and not a lawyer. Oh my God. Martina, a lawyer would have been badass, but like, you in a suit all day, every day. No thanks. You're still very badass. It's just, this is more your vibe. This is your vibe, girl. Well, how did you make the decision to be an in-hospital clinician versus not?
Yeah, well, and it is, when we talk about it, I'm just like, oh, it sounds so dreamy. Or to be a private practice midwife sounds really dreamy, to have like these long conversations with people and really get to know them and really help support them in their dreams. I think part of why I was really drawn to hospital-based birth, but to collaborative practice in particular, is similar to what you said. Like, I really think that it is such a tremendous opportunity for us to deliver really good care to the people that we have the honor of caring for is because, we can collaborate. We can the midwives bring their perspective, physicians bring their perspective, but also like really particular calling back to what brought me to midwifery in the first place was thinking about this work as an opportunity to change someone's experience or influence or affect or shape someone's experience. And also hopefully, because I'm still an activist at heart, change system level and organizational level, like to make changes on an organizational level and to make changes on a system level. And I thought that I could do that more effectively or with greater impact as a hospital-based clinician. I feel like in our group in particular, I'm incredibly proud of that. Our practice is, I think we might be like the largest at this point, non-Kaiser practice in the East Bay. And the East Bay is actually one of the few counties in California where the childbearing population is actually increasing. So at my last job, I was in a different county, and that was something we talked about. Every year, the number of people in their childbearing age in the population was actually going down. But here where we live in our county, it's actually increasing. And so there's a tremendous opportunity to shape the type of care that people get in pregnancy and in birth where we live. Kaiser has midwives. Kaiser is a very particular system, and I've never worked there, so I shouldn't speak to it with much skill or knowledge. But for people who don't have Kaiser insurance, for people who have employer-sponsored insurance or private insurance, our group in particular is one of the largest there is a very high chance that people where we live are going to come and get care where we are. So even as an individual practice, we have so much opportunity to shape and change how we deliver care that will then have an impact on not a small number of people. And so that to me is really exciting because I really think of birth work as activism. I think that we as individual clinicians, like that's where we have an opportunity, not just in our one-to-one interactions with our patients and the people we care for, but with each other, the conversations we have. When Anna and I work a night shift together, we don't get rest. We are either like working or talking the whole time because we want to pick each other's brains. We want to hear how we approach different problems, but we also can then like change, like what's the education that we want to bring to our patients? How do we want to counsel people? What do we want our standard approaches to be? And I feel like the midwives have like our goal in growing out the midwifery service of our group has also been to how do we help protect and preserve the normal physiological aspects of birth? And there are several things that midwives and physicians, just our professional organizations, even have different perspectives about. Like, for example, if someone's labor starts with the water breaking, like it does in 100% of movies, but only 10% of real life, the ACOG recommendation, the OB/GYN recommendation is induce labor right away. But the midwifery group, ACNM, American College of Nurse Midwife, our position statement is wait for up to 24 hours. And so those are different, like this is different medical advice. As when I see someone who's in this situation, I'll say, here's one recommendation and here's the other recommendation. And in our group, we believe in both. So you get to decide which of these makes most sense for you. And here's why or how you can think about it. And I think that's exactly kind of an opportunity to then shift that power dynamic, that it's not us making a recommendation. It's us kind of explaining what the situation is, interpreting the recommendations, interpreting the data and the research and the position statements, and then allowing people to make the best decision for themselves and their family. And I feel like because we have both midwives and physicians in our team, we have multiple perspectives that can help inform people as they make their decisions. And I think that especially as you're caring for a larger population and not a self-selecting population. So not people who are selecting out of hospital birth, community birth, not people who are selecting a private practice midwife, which as you said is often very privileged because you can afford out of pocket. How do we actually provide care to a truly diverse patient population with different skills, with different fears, with different background healthcare knowledge, with different perspectives about pregnancy and birth? It would be irresponsible of us to just bring in a singular perspective. We really have to honor that our patients have different perspectives and that our clinicians have different perspectives. And therefore help people make the best decision for them. That was super rambly. Sorry.
No, you're 100%. You're 100% spot on. Number one, it felt like a pep talk that I didn't even know I needed, in terms of just like reiterating what the beauty of a collaborative practice and the diversity of perspectives that we can offer our patients now. Like I've often said that, at least for me, and I think you're similar, that I was very intentional about working in the East Bay. I've always wanted to care for a diverse patient population, and diversity has no bounds. But in that, in order to honor that patient population, I think it's so important for us ourselves as clinicians to not only be diverse, but also just offer diversity of care. And so I think reiterates that that's something that we have the privilege to be able to offer patients, but also, like you said, agency, right? That the most important thing in any ideal shared decision-making model is that you are always empowering patients to make the decision that is best for them. And so whether it's presenting my take as the MD clinician versus your take as the CNM, or oftentimes we come together and we say, hey, this is our recommendation. This is why. I truly believe from the bottom of my heart, I just want anyone that we're caring for to feel empowered to make the best decision for them. And there are going to be a couple, they're very rare, kind of true, I won't say life and death because that feels a little bit too morbid, but there are some acute scenarios that we see in our job where, hey, we can't necessarily give as much agency in this, like we have to make this recommendation, like this is the only option. But that's fortunately pretty rare. There are most situations where we can present like a united front of, here, thank you for listening to us. We, more importantly, are listening to you. You have agency in this.
And even in those acute situations, the way we communicate that is really important. And ideally, we have had a relationship with folks going, for at least a few hours, if not for days or weeks or months, to build rapport and mutual trust. But even in those acute situations, to look to someone and say, I am incredibly concerned. This is what I see happening. I think we need to do a C-section. I think this is the best thing for you and for your baby. Are you on board? Like that is, it could be a very fast conversation. It's not a full sit down, talk about all the risks and all the benefits. Like you can say, this is an emergency. This is what I'm seeing. I think this needs to happen. If I'm very concerned about your baby, and I think that the best thing for your baby right now is this. In those situations, to at least have that conversation so that people understand what's happening and why it's happening, it takes 5 seconds. And it's so important, because that can also be the difference between something happening to you versus having to make a really tough choice where you say, I understand, this is not what I wanted, but I understand, let's go, let's do this. Like, I understand, I consent, and then have a debrief about it is so important, because there's a potential there to have a traumatic experience be less traumatic, where there's still recognized agency, not like we have to do this, but I'm incredibly concerned. I think this is the absolute best thing to do. Or like, I think we have to have a C-section in order for your baby to be okay. I mean, it's, as you said, it's like, no one wants to say it. Like, we don't want to, often like in the birth world and the doula world, we, would talk about like, doctors always use the dead baby card. And as you said, like that is actually part of our job. And it is unfortunately one of those things that when you care for a large enough population, like that's literally what's on the line. And of course, everybody in the room's goal is to avoid death or grave harm from happening. And so how do you have a conversation, or at least a very intentional interaction about what's happening, even in an emergency, where we recognize that that is, of course, everybody's goal. And that's a very different conversation than like, hey, here's what I'm seeing happening that's coming down the line. Like it's going to be, And so I just want to put that out there, that even in emergencies, it's important to communicate in a way that we recognize that the person that is giving birth is the ultimate decision maker, even in emergencies, even when there's an acute situation.
There's a future episode that will be entirely focused on trauma-informed care, but I think that is really important, what you said about there's a big difference between having something happen to you versus having something happen that you've accepted, whether that's physically, emotionally, spiritually, all of the above. I think I can name like several like very emergent situations in my mind of recent. What I feel most grateful for, whether it's because of the immediate action of, and there's one anecdote I'll give because you were directly involved, or just the debriefing that happened afterwards, where those patients didn't walked away from like a truly life or death situation, not traumatized.
Yes.
At least as of yet, because sometimes trauma comes in
comes
years later. But as of yet, and I really would give props to the entire team involved. It wasn't me. It wasn't the midwife I was on with. It was the anesthesiologists, the nurses, everyone. But there is really something about of a patient feeling like, okay, no, this is not happening to me. Like this is happening, I don't know what the correct preposition is, with me, like of me. But the anecdote I wanted to give.
This is something I'm going through. Maybe that's the preposition is through.
Yeah. Through. Thank you, my lady. I'm very long gone from my third grade English with Mrs. Scroggins. I was like, what's the preposition I want?
Mrs. Scroggins.
Oh, good old Mrs. Scroggins. That's really was her last name. Like I cannot, isn't that the perfect third grade English teacher name? Mrs. Scroggins.
That's great.
Anyway, but the anecdote I recall in very HIPAA compliant, in that it truly was an emergency situation. I think you had already anticipated your concern. You're like, hey, I'm starting to notice this about the strip. And it was one of those very appropriate times where you already had informed me. I think I came in just to meet the patient. I think you had left to do something because of course we're all busy. So I came in just to meet the patient and be like, hey, Martina let me know that she's starting to be a little bit worried about the strip. So I just thought you should know me, and maybe I'll just preemptively just consent to you just in case you need an emergency C-section. And as I was in the room, there was a uterine rupture and there was a terminal bradycardia. But I truly felt like it was a situation where I was already in there. She already knew that you were concerned and knew why I'd come in there. And it was happened to be very fortunate that the very acute rare event happened as I was in the room. But I felt like I can very calmly explain to her and her partner, I now need to do this emergently because that D cell hasn't recovered. And I'm truly worried based on my exam, the baby's head was destationed. I was very worried about everything, that you've had a uterine rupture. And I remember her giving the feedback to her clinician then after of how well cared for she felt and how safe she felt. And that was thanks to you. I physically acted, sure, but you were the one who prompted, this is not normal. There's something that is varying from normal.
Right.
This is a patient who I already know is slightly high risk because of her prior obstetric history. I'm going to get my other colleague involved. And that was to me the epitome of a collaborative practice at its best. It truly was something that I think I have no goddess complex, and that probably was relatively life-saving for the patient and the baby. And it was because you had your own intuition and we were able to work together on that patient's behalf.
Yeah. And trust. Well, thank you for sharing that. And I think trust is the most important trend in that, is that the trust between the two of us, right? That I know that you are there, that I can count on you for when we need that level of care. Trust from you, for me, that I will call you when you're needed. So you can trust that I will take care of things when they're normal, but then identify when they're not. And I think most importantly, trust between the care team and the patient and vice versa. So that this was, as you mentioned, this wasn't something that you and I were talking about behind closed doors. This was a conversation that we were also having with the family and with the pregnant person of, hey, here's what I'm seeing. Here's the trends. Here's what we're worried about. Here's what we're doing to try to ameliorate the situation. Here's what's reasonable to keep considering and keep trying. And if it changes, we're going to change our plan. And so none of this was done in secret. This was all that trust was really built where we through clear communication the entire time. And I think this goes back to also you talked about so much fear around birth. Yes, there are acute situations, but it is extraordinarily rare for those to come out of nowhere. I'd say 99%, maybe 98% of emergencies, or not even emergencies, but starting to be more concerning situations that happen during birth are a pattern that evolves. And so we start seeing early signs and we have that communication. And I think it's going to be a career-long skill of how do you communicate these early signs where you are sharing and collaborating with the families that you're caring for, with the pregnant people that you're caring for, without inspiring fear and stress, without being oh, this is bad and scary, be stressed about this, we're going to have to do a C-section, but more of hey, I'm seeing this. This is what it means. This is why so far I'm reassured. And I think it's really reasonable that we continue towards a vaginal delivery and that we continue to support your labor. If this changes, I'm going to let you know. And then as it changes or if it changes, we continue to communicate of hey, this is happening more frequently. And so I'm a little bit more concerned. So I want to make sure we're going to keep a close eye on it. I want to reassure you that we are constantly monitoring the situation, and this is constantly something that we're worried about so that you don't have to, or that we're thinking about monitoring, here's what we can do in the meantime to continue to be reassured. But if it changes, we're going to have to change our plan. And so that it's an ongoing conversation between everybody involved, most importantly, the pregnant person who's laboring.
Yeah, so well said. We've had heavy topics. We've gone really deep. I'm gonna bring us back to the surface again and talk about. I want to end with a couple lighter questions. Although knowing you and I, we can always figure out a way to like get deep again.
Yeah.
But I'm thinking about that pregnant person who comes into our office day in and day out with a couple of like those most pressing questions that they have. And so like the top 3 questions I always hear people ask that I want to ask you. So if a patient asks you, what do I need to do to be a good pusher? What advice do you give that person?
That's very specific. So I think that's something that we could actually do a lot better. And I was literally thinking about this yesterday as a practice and as clinicians, is really encourage people to be intentional about preparing for childbirth. I think taking a childbirth education class should be absolutely standard for anyone who's planning to give birth. And ideally, like as long as you can, like as deep as a class as you can. But I understand that not everyone has the time or maybe the interest in doing that. And so understanding that we have so much unlearning to do as pregnant people. We have so much unlearning to do of like, what are expectations about pregnancy and birth and what does pushing look like? I think the number one thing that I talk about with people is that we're already, most people who are considering a vaginal delivery are great poopers. We poop without thinking about it, right? Like,
yeah.
We, right before this podcast, I was a few minutes late because I had to go.
It works.
And it's not something we think about. Our body is fine and good at getting solid things out of our body. And it's a pretty much, slightly different hole, but they're right there. The muscle group, the pelvic floor that supports those processes. Like our bodies are good at this. Our bodies are good at birth. Like our bodies know what to do. Our heads get in the way. And I think that it's very different to watch someone who's unmedicated and who is laboring spontaneously. When they get that urge to push, you cannot tell them not to. Like to not push is actually harder than to push. So I think like in terms of preparation, like as much as I say I want everybody to take a childbirth education class, I want to also think about the fact that like we are mammals. And I think the best advice I remember hearing as a doula was let your monkey brain do it. Let the part of our human brain that are apes, not monkeys, take over and do that, right? Like hamsters don't take childbirth education classes and they have 100% vaginal delivery rates, right? And so of course there's like physiologically, like we're a little different, like our skulls are different, the shape of our bodies, the way of being bipedal and all that. But at the end of the day, this is a normal process and our body is an expert in doing this. And one of our coworkers, Gwen, said this really nicely. She goes, your body is an expert in something you've never done before. And I really like that I think we forget that, we think about like, well, I've never done it before, so how will I know what to do? And really it's for the majority of human history, for the majority of humankind, we have given birth with the support of skilled people who have done it before, who know what to expect, who can help keep things in a normal, safe place. The World Health Organization will recognize that, 10 to 15% of births might need to be a C-section to maintain ideal maternal and infant mortality rates to save lives, but that for the vast, vast majority of people, you can be a good pusher by getting out of your head and letting your monkey brain do it.
Yeah, so well said. And I was trying to remember the Gwenism because that's another phrase that I say that, your body is meant to do this. You are an expert at it already. And so I love, we talked about encouraging our patients, empowering our patients, and that is just a beautiful way of doing it. Okay, my next simple question, how do I help reduce perineal tearing? Great question.
And I want to assure everyone that we are all very motivated for people to have as little tears as possible. It's great to not have to do stitches. So I think often people, I want to reassure sometimes that like, I need to reassure people of like, trust that we have this as a shared goal, not just for your experience, but like for our as clinicians to just, of course it'd be great for your body to not need additional work. So the research that I'm most familiar with shows that the most effective strategy to reduce perineal tearing is to push in the position of the birthing person's choosing. So avoiding the sort of hospital-based default of having everybody kind of leaning back in like stranded turtle. I sometimes will call that like a reclining squat, because I do think like a squat position for our pelvis is what our body prefers most of the time. And often people's positions and the ability of them to push in different positions is going to be affected by if they have an epidural or not, right? Like, are you able to be upright and support yourself? How can you rest effectively? The longer people push for, the more positions we try. But really, at the end of the day, that's the single most effective tool for reducing perineal tearing, is that listening to the people who are giving birth and supporting them and pushing in the positions of their choosing. But the other things, I know there's some research about perineal massage prenatally. I'm less familiar with that. I think it's one of those things where it can only help, it can't hurt. And it helps you communicate, like it helps your brain and your perineum communicate of how do you cope with discomfort? How do you breathe through discomfort? How do you connect to that part of your body? I think all of that can be really beneficial. But for the moment of actual birth, more than anything that the clinicians do to support the perineum, I think there's also some evidence that warm compresses can also reduce tearing. So we try to use those as much as possible. But really, it's allowing people to be in the position of their choosing. And if they choose to push on their back, then we support that as well.
Yeah, exactly. And then you've already given me some hints to multiple answers to this question, one including group prenatal care, and I think also doula support. But another question that patients often ask are, what are your group C-section rates and what can I do to prevent a C-section? How would you advise that patient?
I would recommend that they get a doula. As you said, that is the single most effective intervention for reducing C-sections. I would encourage that they work with a midwife, because statistically that's also been shown to reduce C-section rates if you are a normal low-risk person. Those are kind of my big things in terms of things we have. You mentioned this earlier about, the control of what little we have. Like I think that there's so much of labor and birth that is the biggest lesson is about surrendering to the process and like letting go of the process and thinking about, what do you have control over? What do you not have control over? And based on your insurance or based on financial situations, based on your preferences, based on your medical history, you might not be able to choose exactly where you give birth and who your care team is, but you have control over so much else. Like, who's your support system? Getting a doula. Who is like, what's the vibe in the room? What's the control the lights, play some music? How do you make a hospital room feel as safe and homey and comfortable as possible so that the thinking part of your brain can shut off and your body can really take over? How do you help yourself feel safe?
You've probably captured so many different things that I'm hopeful our audience will be able to kind of instill within themselves and help themselves be able to reframe either their future birthing potential or even past experiences. What is your top piece of advice for any person who is either currently pregnant or planning to birth? What would be your main top 3 takeaways? If you could pare down,
just an easy question.
All of your wealth of knowledge. Let's end it on a light note.
Yeah, let's just end on a light note. What's the most important thing to do? Are people who maybe tend to be planners, people who maybe are trying to optimize. And I will identify myself as a planner and the type A flavor that likes to optimize everything. And so I think that I'm not gonna do a neat top three things answer, but rather I want to question the question itself. I think that it's an opportunity for people to think about letting go of control. And I don't mean give control to other people. I mean specifically thinking about the power and that your body has, and that your body is going to do what it's going to do, and having as much of a relationship of how, having that relationship with your body, of knowing how to listen to your body, learning how to take directions from your body. I think our bodies are really good at giving us directions, but we are really bad at listening to them. And so I think that a lot of the work of preparing for a good pregnancy, preparing for a good birth, is that relationship between you and your body, and knowing that maybe your brain and your expectations and your desires are not always what your body's going to do. But how do we honor and support that and celebrate that, even when it sucks, even if it means throwing up for 30 weeks for worst case scenario kind of things. It is such an incredible thing that your body's literally creating another person. This is comic book stuff, science fiction craziness that we see. And just that's so much work. I think that changing the perspective around pain in labor, I think is really important. And Penny Simpkin, who she was the founder of the doula organization in North America, DONA, a physical therapist who really created a lot of writing and popularity around doula support. Anyone who's pregnant, and really anyone who's supporting someone who's pregnant, I recommend getting The Birth Partner by Penny Simpkin to read about, to both honor the partner's experience throughout pregnancy and birth, but also about how to provide effective support. She talks a lot about the difference between pain and suffering and work and suffering. When we see someone like doing an extraordinary physical activity, like when I watch the Olympics, I'm not like, when I see someone like lifting like crazy hundreds of pounds of weight, like I would literally die and like get crushed underneath that. Right. But I don't feel sorry for them. I'm not like, oh gosh, they're such a martyr. Like I think about like, wow, they are working so hard. They're doing such extraordinary things with their body. And I think that I feel that way when I watch people labor. Right. And so especially with the choices about pain medication and labor, you often hear that language like, oh, well, you don't have to suffer. You don't have to be a martyr. And I completely agree. You should not be suffering. And how do we recognize and support the work, the physical work of labor, and really support it as such? Like when we see people running a marathon, we're not thinking about how much they're suffering. We're thinking about, wow, they're so strong. They're working so hard. But that said, if I ran a marathon, I probably would be suffering. So this is why we have choices, both in terms of if you choose to run a marathon or not, but also if you choose pain medication or not. I think that what I want to end on is that like the advice that I give every centering group and every friend or family member who's pregnant is that there's this like old woo-woo midwife saying that you're given the birth you need to learn the lessons that you're going to need to know to parent this child. And I have never been part of a birth, whether it's totally woo-woo, candlelit, home water birth, or whether it is, stat C-section for an acute medical complication, or everything in between, where the biggest lesson and takeaway was not that you are so much stronger, where the biggest lesson was not you are so much stronger than you ever realized, and you can handle so much more than you ever thought possible. We don't know what our kids are going to be like. We don't know what kind of parent they're going to need and what kind of parenting they're going to need. We don't know what our births are going to be like and what our labors are going to be like. And there are times that we can control certain factors, but there's so much we can't control. But surrendering to the process, trusting that our bodies are experts in this process. Our entire lives that we've lived up until this point are going to help inform the way that we make the decisions that we're able to make. And that those are going to be the right decisions for us at the time, I think is the most important thing.
I feel stronger just hearing you. I feel empowered. And I'm sure anyone who's been lucky enough to listen in feels the same. I want to assure you that you're coming back. You're going to be a multiple stop guest.
Yay!
And that I already have planned that we're going to have an episode to talk about non-pharmacologic versus pharmacologic pain management and labor. So we were going to do a deep dive in all of that.
Can't wait.
So just a little plug. But in the meantime, in all honesty, I'm honored to not only call you a colleague and a friend, but even more so recognize that it's truly an honor for us to care for the vast community of birthers that we get to care for. And I think the ways that you kind of describe self-empowerment, demystification, and also just giving in, and there's power to vulnerability as well. I couldn't say it better myself. So again, thank you for being you. Thank you for being so rich of not only of deep thought, but beautifully spoken word.
Oh, coming from you, that means a lot. Thank you, Anna. Thanks for letting me talk about the things I care about.
Yeah. The passion is real and it's contagious. Well, thank you again, Martina. We are so grateful for your time. And this concludes our episode. Thanks again.
Awesome. Thank you.
Thank you very much for listening to The Golden Hour, the podcast community where moms and moms-to-be can hear stories from other mothers and learn from top experts in pregnancy and postpartum care. If you enjoyed this episode, please take a moment to like, subscribe, and share with your friends so we can reach more people like you. You can visit goldenhour.fm for more information, resources, and all other episodes. If you have any requests, questions, or suggestions for future episodes, please email me at hello@goldenhour.fm or leave us a comment at goldenhour.fm on Instagram. Looking forward to seeing you in the next episode. Until then, stay golden.